Welcome to the instruction course of the secondary mirror telescopic implant, the OriLens. It is the first pseudophakic mirror telescope in the world. As you will learn, it can be used for pseudophakic as well as for phakic AMD eyes. The first generation intraocular mirror telescope, the LMI, the Lipschitz macular implant, was designed for phakic eyes only. The newer generation OriLens, which we describe here, is a pseudophakic, sulcus-fixated PMMA mirror telescopic implant. This course includes several parts. First, we shall explain briefly the advantages of intraocular telescopes as compared with external telescopic devices. We will specifically point out the advantages of the mirror telescopic technology as compared with the other options. Then we shall describe the OriLens, its optical characteristics, mechanical properties, the indications for use, and the performance. Later on, we shall go through the pre-op considerations, including patient selection criteria, particularly the process of testing whether a given patient can benefit from the surgery or not. In a separate section, we shall discuss the OVT, Optolite Vision Testing Program, and explain how it can speed up and facilitate the patient selection process. We will also discuss the surgical procedure and post-surgical treatment, as well as complications and how to avoid them. So let's begin. I hope that you will enjoy the presentation. The optical implant for AMD is an anterior segment surgical approach for improving vision of AMD eyes. The OriLens, however, is not limited to wet-type AMD. It can help dry-type AMD eyes as well. The growing number of elderly patients suffering from AMD creates the need for immediate help, and we are here to help them. Our mission at Optolite is to develop intraocular implants for helping patients who suffer from AMD and other retinal diseases. AMD, after all, remains the last challenging frontier for cataract surgeons after we've overcome presbyopia. The demand for AMD treatment is expected to grow with the aging of the population. This is the future of medicine and cataract surgery. AMD is the most prevalent disease requiring treatment that can be helped by the OriLens. We need to remember one fact. Medical treatment for AMD is available only to a small group of 10 to 15% of AMD eyes. Those who suffer from wet type, and even these eyes are not cured but rather transformed into dry type AMD. 85 to 90% of AMD patients suffer from dry type AMD, and they have no treatment options at all other than taking vitamins. The OriLens may potentially help both dry type and wet type AMD patients before or after using any other medical treatments. Note that any telescopic magnification reduces the contrast, since the same amount of light falls over a larger area. The decrease in contrast is proportional to the amount of magnification. Before starting, let's go over some points summarizing what we are dealing with. This is a new group of surgical patients for the anterior segment surgeon. We are not talking about complicated surgery. We do not intend to cure the disease, which is impossible. What we are trying to do is to help the patients function better with the disease. This requires a long-term commitment to the patients, since they tend to come back. Furthermore, patient selection for the procedure is complicated. Finally, it is very difficult to make these patients happy and satisfied over the long term. Because they suffer from a progressive disease, they are elderly, they do have high expectations, and encounter difficulties in adjusting to their new situation. The concept of implanting an entire telescope inside a human eye was first suggested by Dr. Isaac Lipschitz in the late 1990s, when he started a company by the name of Vision Care Ophthalmic Technologies and developed the IMT, the implantable miniaturized telescope. The IMT was a regular Galilean telescope inserted inside a PMMA IOL. Since then, Dr. Lipschitz left the company and later developed a mirror telescopic implant that has many advantages over the older telescope, as you will learn soon. It is important to understand that the implantable mirror telescopes are complementary to any other medical treatment that an AMD eye can receive. It is not intended to replace any other medical treatment. This provides additional assistance to these eyes above and beyond any other medical treatment. Implanting a telescope is the only way to improve vision for these patients. The OriLens, when suitable, can be used for any type of AMD and at any stage of the disease. The first question that everyone might be asking is, why do we want to implant the telescope within the eye? Why not use an external telescope as has been done for decades? The main disadvantage of the external telescope is the constant relative movement between the eye and the fixed positioning of the telescope. This doesn't occur when the telescope is implanted within the eye. Because the entrance pupil of the external telescope is always small and the eye is constantly moving with respect to the telescope, the patient has to move his or her head in order to see the magnified image, and that's very difficult for elderly patients. When the telescope is implanted inside the eye, it moves with the normal eye movement so that there is no need to move the head. Thus, it is always positioned in the field of view. Yet another advantage is the wider and more comfortable visual field. Last but not least is the cosmetic and functional aspect. This is just to get you focused on what we are talking about. Here is a schematic drawing that shows how the OriLens is positioned within the eye. As you can see, the implant is positioned anterior to the regular IOL, and the loops are fixated within the sulcus. The entering light first hits the annular ring posterior mirror, then it is reflected to a second and more anterior round mirror, and from there it passes through the regular IOL to the retina. So as you can see, a small letter A that usually falls on the degenerated area is now magnified and easily recognized by peripheral existing photoreceptors in the retina. Here is a short video of the very first worldwide implantation of the OriLens. We start after removing the cataract. Here is the implantation of the regular in the bag IOL. The incision is enlarged to 5.5 millimeters. The OriLens is inserted. First goes the upper loop into the sulcus, and then the second loop follows. Finally, the removal of viscoelastic and suturing of the incision. As you can see, the surgery is very short and simple to perform. Let's spend a moment to compare the mirror telescope with the other devices that can be used for intraocular magnification for AMD eyes. IMT, Intraocular Miniaturized Telescope. This is a Galilean telescope. It is big and long, and it bulges into the anterior chamber through the pupil. IOL VIP, IOL for vision improvement. These are two lenses. One is highly myopic, minus 53D, placed in the bag, and the second is highly hyperopic, placed in the anterior chamber. The newer device is the OriLens, a mirror telescope for secondary implantation. The IMT and the OriLens create roughly 250% magnification, while the IOL VIP creates only 25% magnification, which is not good enough for AMD. The visual fields are also different. The IMT completely occludes peripheral vision and magnifies only the center, while the IOL VIP mildly magnifies the entire visual field. The OriLens magnifies only the center and enables at least part of the peripheral field to remain unmagnified. The patient selection criteria are also different. The IMT is intended only for end-stage AMD and for monoocular use for phakic eyes. The IOL VIP is also intended only for phakic eyes, but only for those with mild AMD. The OriLens is intended for phakic and pseudophakic eyes and at any stage of the disease. The main objective of using the OriLens is to create a magnified image on the macular area and by so doing to improve the vision of AMD patients. The OriLens looks like a regular PMMA IOL. Its diameter is 6 by 5 millimeters, so it can be implanted through a 5.5 millimeter incision. It contains loops that look like normal IOL loops. They are 13.5 millimeters in diameter and are angled at 12.5 degrees, pushing the implant backwards. The only important difference between the OriLens and a regular IOL is its central thickness, which is 1.25 millimeters compared to less than 1 millimeter in regular PMMA IOLs. The implant is designed to be fixated in the sulcus over an existing in-the-bag or bag-in-the-lens IOL. What is the advantage of a mirror telescope as compared with a regular refractive telescope? The magnification of a Galilean telescope depends on the difference in the index of refraction between the different media that the light passes through. That is why the IMT is so long, 4.6 millimeters. By creating a telescope using mirrors, we do not depend on the index of refraction of the media, but mainly on the curvature and positioning of the mirrors. That, by the way, is why astronomical telescopes, such as the Hubble, are all mirror telescopes. The mirror telescope can achieve large magnification in small volumes, and as we all know, there's not much volume inside the eye. Another reason why we want to use mirrors for the telescopic effect is that we create a projector's effect and we can increase the size of the image and modify other parameters such as contrast, color, and visual field. This is done by changes made to the mirror coatings. The mirrors that reflect the light inside the eye can be manufactured using biocompatible materials. Let's review some details about the OriLens. It can be used for up to 80% of all eyes suffering from AMD. It can be implanted in both eyes depending on pupil size and the existence of peripheral vision. It is surgeon-friendly and can be implanted by any anterior segment surgeon. It is easy to implant and enables quick recovery. It does not damage the corneal endothelium as other intraocular telescopes do. Finally, it is complementary to any other medical treatment and can be used for some other retinal diseases as well. The first generation mirror telescope, the LMI, could only be used for phakic eyes. About 70% of the patients that need an intraocular telescopic implant are already pseudophakic. The OriLens was specially designed for pseudophakic eyes, and it is the only intraocular telescope available for that purpose. There is no need to explant the previous IOL in order to have the mirror telescope implanted. The OriLens is positioned in the sulcus over the existing IOL, which is in the bag. The OriLens can be implanted over any type of IOL, including aspheric lenses. However, it is still unclear how it would function over an existing multifocal lens. Although it was originally designed primarily to help AMD patients that have already undergone a cataract surgery, as no other surgical option is available for them, the OriLens is frequently used for primary phakic eyes as well. In this instance, the surgeon first performs a normal cataract surgery using his or her lens of choice, and then increases the incision and implants the OriLens over the IOL that was just inserted. Furthermore, the procedure is reversible. If there's any need to remove the OriLens due to changes in the condition of the eye or for any other reason at all, it can be easily removed with no damage to the eye. This is an enormous advantage over the other telescopic implants. Intraocular mirrors and evolution. When we started the project of implanting mirrors inside the eye several years ago, we thought that it might create unanticipated problems. After all, it was never used inside living eyes. But fortunately, several years ago, a group of European scientists found the first creature that uses mirrors to direct light towards its retina. It was found deep in the ocean, 700 to 1200 meters deep. This was unknown to us when we started to develop the idea of using intraocular mirrors inside a human eye. But the fact that nature developed such a possibility proves that a mirror can actually be used for directing light towards the retina. So we are happy to declare that God or evolution was first, and we're just following what was created by nature, not trying to play God. So how does it really work? Well, every telescope, whether internal or external, works on the same principle. It creates a magnified image on the center of the posterior pole. The area of that image on the retina includes the degenerated macular area as well as a more peripheral area. This area has viable photoreceptors and can transmit the signal to the brain. The brain knows how to fill in the missing areas so that the patient gets a full picture. So basically the question is if the projected image is reflected on a large enough area so that it can still generate an image in the brain. That is why patients with a larger area AMD cannot benefit from a specific telescope, and they need a higher magnification that will reflect on a larger area and thus enable them to recognize the entering image. This is the very same image that you saw before, a schematic drawing of the OriLens inside the eye. The OriLens is a secondary implant placed in the posterior chamber. It is sulcus fixated over an existing regular IOL, which is positioned in the bag. Both lenses together, the OriLens and the IOL, together with the corneal power, create a telescopic effect that magnifies the image 2.5 times, in other words, a 250% magnification. As mentioned before, the OriLens has only 1.25 millimeter central thickness, and it can be used in combination with any posterior chamber IOL. The miniature mirrors, having a diameter of about 0.5 to 1 millimeter, are embedded inside the implant. They are configured very accurately and positioned precisely so that they create a Cassegrain telescopic effect, together with the corneal power and the regular IOL power. The positioning, curvature, and distances of the mirrors require sub-micron levels of accuracy. We need 100 nanometer accuracy in order to get good optical results. The light reaches the central mirror first, is reflected towards the second mirror, and then projected towards the macular area. The telescopic part of the implant is located in the pupil, but does not cover the entire pupil so that it may allow some peripheral light to enter and enable some peripheral vision. We will discuss this in a moment. Images that are normally directed towards the macular area are captured by a mirror that is located in the visual axis. After capturing the image, various optical elements that are incorporated inside the implant project the newly modified image onto the retina. The effect of the OriLens on vision can be compared to changing a TV set into a projector. With a TV, the object and the image are always at a certain size, and the image is always directed towards the macula. But when using a projector instead of a TV, we can modify many parameters that we can't modify with the TV. For example, we can change the size of the picture, the contrast, the field, or project only part of the image. So what we are actually doing when using the intraocular mirror technology is creating an intraocular projector. This is what you saw before, a schematic view of the OriLens inside the eye and the magnification that it creates with the corneal power and the regular implanted IOL. This is a side view of the OriLens. Note that it is only 1.25 millimeters thick. Here is a front view of the OriLens. In the center you can see the telescopic mirrors, and in the periphery the pupil and the contrast adjuster for the peripheral field. This is how a patient with the OriLens sees the world as compared with normal visual field. Only the central field is magnified while the periphery stays normal. This helps for orientation in space and for seeing the entire image. Visual field. The OriLens concept is unique in the way that our patients see the world. Unlike presbyopic IOLs that have two dioptric powers, for distance and for near, the OriLens system may also create two visual fields. The visual field of the OriLens patient comprises two parts, central and peripheral, and each of them can be focused or defocused for distance or for near. The existence of the peripheral field is always pupil dependent. Each of these two fields can be modified compared to the other by changes such as color, giving one field a different color than the other, by contrast, and by focal distance or defocus. The central image, which is the magnified image by approximately 250%, is projected onto the macular and perimacular area of the retina, and the peripheral image remains non-magnified. Pupil size is an important factor in the way that a patient can see the world following implantation. If the pupil is too small, below 2.5 millimeters, there is a problem because of the reduction in the amount of light that reaches the first mirror, and there is also no peripheral vision at all. If the pupil is 2.5 millimeters, the patient sees the central vision very well and with good contrast, but still there is no peripheral vision. When the pupil is between 2.5 and 4.5 millimeters, there is central magnified vision as well as peripheral vision. As the pupil enlarges further, the peripheral vision contrast increases, and at 4.5 millimeters, the central and the peripheral illumination are roughly equal. If the pupil is more than 4.5 millimeters, the patient experiences glare that will disturb his or her central vision. The OriLens contains a double optical system. It can be adapted to defocus the central image from the peripheral image in order to help the patient distinguish between them. For instance, we can create an OriLens where the peripheral image is focused for 6 meters distance, while the central magnified part is focused for near 30 centimeters, or in any other combination between the two optical systems. The amount of defocusing between the two systems has to be predetermined and cannot be changed once the implant has been manufactured. This is an important advantage. In the future, we may even be able to design the OriLens according to each patient's specific needs. Currently, the OriLens is designed so that the magnified central image is focused for 60 centimeters, so that we can increase the magnification for near by bringing it closer to 30 centimeters, and the peripheral field is focused for distance. The depth of the focus of the implant is 1.5 diopters. The LMI and the OriLens are not intended to replace any medical treatment for AMD. OriLens implantation is a complementary treatment to all types of medical or surgical treatments that are used or can be used to help the patients suffering from this disease. These treatments can be performed before or following the implantation of the OriLens. That's why the OriLens is indicated for all types of AMD, eyes with wet, dry, or even end-stage AMD. The OriLens may be used as a bilateral implant in both of a patient's eyes. If only one eye needs medical attention, it does not interfere with the implantation in the other eye. The OriLens may be used not only for AMD patients. Here is a partial list of medical conditions in which patients may benefit from the use of the OriLens implant. Basically, it can be used for any central retinal macular lesion. An important target group is the group of patients who suffer from albinism. These patients need only mild magnification, approximately 60 to 80%. That can bring them from around plus or minus 20/60 to 20/40 so that they can drive and function better. Malignant myopia is another interesting group, and even patients with diabetic maculopathy, if a retina that was treated before is currently stable, can be treated. So, before proceeding, let's sum up. What have we learned so far? The OriLens is a telescope that uses reflective optics and has multiple advantages over other implanted devices. It can be used for any type of AMD as well as for other central retinal diseases. It may preserve at least part of the peripheral vision. It's easy to implant. It can be explanted if needed. And it magnifies the image for distance and for near. Now let's jump into the clinical part. We shall start with the pre-op clinical considerations. As with any other surgical procedure, the patient has to be well informed and the expectations have to be realistic. Not every patient is a good candidate. The patient screening procedure is thus very important and has to be performed meticulously. Then we shall go over the patient selection exclusion criteria and the patient examination process. We shall also discuss the OVT, Optolite Vision Testing Program, and the need for an external telescope examination. Finally, we will discuss patient educational aspects. So who is a good candidate for this implant? 1. Bilateral AMD or other macular diseases. 2. AMD dry type, wet type, scar stage, or other similar lesions. 3. Visual acuity ranges between 20/60 to 2400 in each eye. 4. No other ocular diseases other than cataract, pseudophakia, AMD, or other macular lesions. 5. Visual acuity improved for distance and or near when tested with 2.5 time magnification using an external telescope and or the OVT program. 6. No previous eye surgery other than cataract. 7. No other systemic diseases. The patient takes no medicines which contraindicate eye surgery or may affect the results of the implantation surgery. 8. Easy to communicate with, responsible, and understands his or her condition. 9. Available for follow-up 1 year post-op. 10. The patient is motivated for implantation of the OriLens, knows the risks and the potential benefits that are involved, and is highly motivated to read and improve his or her visual capabilities. 11. Ready to sign an informed consent form. 12. Has successfully undergone all of the pre-op eye examinations. Who is not a good candidate? 1. The patient does not fit into the above-listed inclusion criteria. 2. The patient suffers from other ocular or retinal problems that can interfere with the surgical procedure or with the post-op treatment. 3. The patient does not understand the fact that this is a new device. He or she is unable to communicate clearly, does not understand the requirements and the risks involved in the implantation, or is unable to show up for the follow-up examinations. 4. The fellow eye suffers from medical problems which would not enable the patient to use his or her peripheral vision. 5. The patient suffers from a systemic disease or allergies to the medications that can interfere with the surgery or the post-op treatment. Before surgery, the following tests should be performed. 1. Full medical eye examination, including slit lamp, IOP, cornea, iris, anterior chamber, lens, vitreous, and retinal examinations. 2. Confirm that the pupil on the operated eye is central. If it is eccentric, a pupilloplasty can be considered during surgery. 3. Distance visual acuity performed in each eye separately. ETDRS acuity with best correction. 4. Near visual acuity performed in each eye separately. ETDRS acuity with best correction. 5. Visual acuity with 2.5 times external telescope, best corrected distance and near on each eye, ETDRS. 6. We expect to get at least 3 lines, 15-letter improvement on ETDRS in order for the patient to qualify when tested with the external telescope. 7. Cyclopedic refraction. 8. Specular microscopy, endothelial cell count. 9. A-scan, anterior chamber depth and IOL calculations. 10. Keratometry, K-reading, or corneal topography. 11. Fundus and macular area photography. 12. OCT or fluorescein angiography. We can estimate preoperatively the amount of vision improvement that is expected for a certain eye. It may be important to demonstrate the potential results to the patient. The OriLens has a unique feature which enables us to test before surgery and to predict the optical results of the implantation. This can be done by using an external telescope with the same magnification, 250%, and demonstrating to the patient what he or she may be able to see once the image is magnified. It is the most important test in the inclusion criteria since it can give us a sense of possible post-op vision for distance and for near. Optolite developed a testing method to help in the pre-op and post-op vision testing, called the OVT. Vision testing before OriLens implantation. The specially adapted computer program is called the OVT, Optolite Vision Testing Program. The OVT can serve as a simple and quick method to screen patients and check whether they are suitable candidates for implantation. It can also serve as an adjunct to the final optometric testing before surgery as well as for the post-op testing. The OVT is still not completely validated, so we do request that before the final decision on surgery, each OVT result will be validated by a traditional optometric testing. In order to test the patients, you will need an external telescope with 2.5-time magnification. If you do not have one, please find reference and guidance for buying it at the end of this presentation. The traditional procedure of patient selection for OriLens implantation may be time-consuming. Optolite designed this program in order to find a way to facilitate the patient selection process and, even more important, to standardize the testing results. The goal of this program is not to find the exact maximal BCVA with and without the use of an external telescope. It is designed to demonstrate whether a certain predetermined improvement in visual performance post-op may be achieved compared to pre-op vision without the telescope. This will enable us to decide whether or not a patient is a good candidate for implantation. If we really want to find the maximal potential vision of an eye with a telescope, it can be done only by testing with an external telescope in the traditional way. When using this program, you will be able to evaluate whether the tested eye will achieve an improvement in vision that justifies performing the surgery. 3 lines. The program and the manual for using it are supplied free of charge. The program can be installed on any computer. It also allows data handling and printout of the results. The program can be used for 1. Testing before implantation for the patient selection process. 2. Simulating the contrast inside the eye after implantation and testing vision with that contrast. 3. Testing after implantation for follow-up. All of the tests are performed using the same setting and the same principles of work, so the improvement after implantation can be demonstrated. For a demonstration of the OVT program, please refer to our separate special slideshow. YAG laser treatments. We do not know yet the effect of YAG laser on the special coatings that the OriLens contains. We already know that the mirrors are not compatible to YAG laser and are damaged if YAG laser is applied. So it's contraindicated to use the YAG laser on OriLens operated eyes. If it is necessary to perform a capsulotomy, use a pars plana needle approach. This slide shows what can be seen in retroillumination. As you can see, we can examine the retina fairly well when looking from the side, but regular OCT cannot be performed on these eyes. This is an anterior segment ultrasound that shows the distance between the 2 lenses. As you can see, there is a fine distance between the 2 lenses of 0.6 millimeters in this particular eye. We shall now discuss the surgical procedure. Anesthesia, according to the surgeon's preference. Pre-op diamox, to reduce vitreous volume in pseudophakic eyes. Incision, corneal or limbal, according to surgeon's preference. Size of incision, 5.5 millimeters. If the eye is phakic, a routine phaco or ECC procedure. Peripheral iridectomy should be done pre-op or surgically. YAG laser, however, should not be used after surgery. Viscoelastic on the entire implant. Fill the anterior chamber before insertion of the OriLens. Grasp the OriLens by the loops or the base of the loop. Please do not touch the lens optic with forceps. Insertion of OriLens. The posterior mirror, ring-shaped, should point towards you. Place both loops in the sulcus. Remove all the viscoelastic. Eye closure, suturing, according to surgeon's preference. Subconjunctival injection of steroids and antibiotics. Pre-op and immediate post-op medications as in irregular cataract. Post-op treatment. 1. Consider using an eye shield for 2 days. 2. Post-op tests are recommended at 1 day, 2 days, 7 days, 30 days, 3 months, 6 months, and 12 months following implantation. 3. Antibiotic and steroid drops times 4 for the first week and then as usual. 4. Slit lamp examination, but watch for anterior synechia. 5. IOP. 6. Position of lens pupil. The posterior annular mirror should be fully exposed and in the center of the pupil. 7. Refraction. Only manual refraction with the help of the table that we supply is possible. Autorefractometry or retinoscopy cannot be used. 8. Visual acuity, distance and near. UCVA and BCVA for distant and for near using ETDRS. 9. Specular microscopy. 10. Record any side effects on each visit. 11. Record the effect of light conditions and pupil dilation on central and peripheral vision. 12. Medical ocular follow-up as in regular cataract. Now we shall discuss the results. Here are the results of 2 series of patients performed with the older model of the implant, the LMI. You can see that in Group 1, an average improvement of 3.6 ETDRS lines for distance and 4.9 ETDRS lines for near were achieved. In the second group, 1 line for distance and 4 lines gained for near were achieved. The reason for the result of 1 line was found to be the pre-op testing, which was not performed meticulously. This cannot happen when using the OVT. As you can see, there were only minor side effects and complications. Here are typical results of OriLens implantation. At 6 months post-op, visual gain 2.5 lines for distance and 4 lines for near. Another example, 6-month visual gain with the OriLens. You can see the 3 lines gain for distance and 3 lines for near. Here we have a 4-month result of another patient. This case was done in a bag in the lens technique. And again, 4 lines of improvement for distance and 3 lines for near were achieved. Here is another surgical video. This surgery was performed by Professor Marie-Josée Tassignon from the University of Antwerp, Belgium. This surgery is done after a cataract surgery, which was performed using the bag in the lens technique. Complications. As in any surgery, complications in OriLens implantation may occur. Positioning of the mirrors. Avoid decentered lens. At the end of the surgery, the central mirror should be positioned in the center of the pupil, and the annular posterior mirror surface should be fully exposed, that is, pointing outside towards the cornea. Late decentration. Reposition the implant into the proper location. Relations between the central mirror and the pupil. In the case of an ectopic pupil, confirm that both loops are positioned in the sulcus. The pupil should be kept mildly dilated, or pupilloplasty, sphincterotomy, can be considered. Post-op inflammation. Treat vigorously and immediately, including pupil dilation. Synechia. Avoid synechia by dilating the pupil during the first few days after surgery. Lens inserted upside down or inverted. Note that the central mirror is placed so that the anterior small round mirror surface will point inside towards the retina, and the posterior annular surface mirror should face outside towards you. Epithelial edema can be caused only when inserting the lens. Treat as usual and follow up carefully. Explantation of device. We may have to explant a certain percentage of implants because of progress of the disease, problems with surgical technique, tilt, or patient dissatisfaction. The good news is that it should not be much of a problem to explant it. Comparison of anti-VEGF treatment and the OriLens. The anti-VEGF treatment is only for wet type AMD, which comprises only 10 to 15% of AMD patients. The OriLens is intended for dry type and wet type patients. We shall try and compare the two treatment modalities. As can be seen from the table here, the OriLens has a potential to treat almost all of the AMD eyes, while the anti-VEGF has the potential to treat only 15% of those eyes. Anti-VEGF treatments comprise multiple injections, while with the OriLens we intervene only once. With anti-VEGF, the stability of the effect of the treatment decreases over time and requires enhancements, whereas the magnification effect of the OriLens is not reduced over time. The cost of the multiple injections over time should be compared with the one-time cost of the implant and one-time surgical fee for the OriLens. When injecting an eye, the results cannot be predicted, whereas before implanting the OriLens, the benefit in terms of vision can be simulated, assessed, and demonstrated to each and every patient. The good news: both treatments are additive, so a patient who has been injected can have further improvement with the implant, and an implanted patient can be injected. The anti-VEGF treatment is not reversible, as you cannot remove the injected material, but the implant may be removed fairly easily with little hazard to the eye. Side effects of injections grow considerably with the multiple treatments that are usually needed, whereas the side effects of the implantation are similar to a routine cataract surgery. The only advantage of the VEGF is that it is CE and FDA approved, whereas the OriLens is only CE approved and has not yet been submitted for FDA evaluation. There are problems of compliance with the anti-VEGF treatment which do not show up in the FDA-controlled studies. These do not exist when using the OriLens. Let's have a look at the Lumiere study. This is a retrospective study that was performed in 16 centers in France and presented at Arvaux. It looked at the compliance and practice of VEGF treatment. As you can see, most patients did not comply with the multiple and long-term treatment. Only 40% got the full induction phase, and only 4% had regular follow-ups. There were 8 yearly visits on average, with an average of 5 injections, and the improvement was only 3 letters. Only 20% got 3 lines or better at year 1. We believe that OriLens implantation can favorably compare with these results. As you have already learned from this presentation, Optolite pioneered some new concepts in ophthalmology. We at Optolite are very proud of this contribution and hope many others will follow the path that we have paved. Optolite was the first to develop and implement the concept of using intraocular mirrors, reflective surfaces, inside the eye. Until now, only refractive and sometimes diffractive optical elements were used in ocular implants. We are proud to add reflective optical elements, which can be used together with refractive and diffractive elements to be implanted inside the human eye. Optolite was the first to present the concept of blocking the entering image from reaching the macula by acquiring the image using a mirror that is placed in the center of the visual axis and preventing it from going directly to the macula. After acquiring the image, it goes through a process of changes, and only after being manipulated and changed by other optical elements is it projected onto the retina. Optolite was the first to implant inside the eye an optical arrangement that includes two optical systems inside one IOL. One system magnifies the central image and another one that does not magnify the image. In so doing, Optolite developed a whole new concept of visual fields. The images that are projected onto the eye after being manipulated by the optical arrangement include a magnified center and a normal periphery. Optolite proposed the concept of creating an intraocular projector inside an eye. The image is projected onto the retina after being adjusted in size, color, visual field, and contrast. And finally, Optolite created the first IOL that involves nanometric accuracy. In order to get good performance inside the eye, we create implants with 100 nanometer accuracy in order to function properly inside the eye. The core technology that we developed is a basis for more innovative products. Here are some examples of what we are working on now. The 4 times magnification compared to the 2.5 times that we have today. OriLens for albinism, mild magnification that would improve their vision from roughly plus or minus 20/60 to 20/30 on average, and thus enable them to drive. Telescope on demand, a new concept of an implant that can be used only when the patient wants it and is not in use when he or she does not want to use it. The OriLens technology is synergistic to cataract surgery, and implantation can be performed by any cataract surgeon. There's no need for capital investment in equipment or in surgical devices. There is a large group of patients that have no other option. The surgery is simple. It is reversible and the implant can be removed if needed. And finally, it is additive to any other retinal treatment. So, why don't we get started? The first step is to become familiar with the implantation manual, which Optolite supplies. Then you can obtain the OVT program and get used to it. Next, you should select the right patients by using the program and confirm with regular optometric testing. It is important that you have an external telescope, 2.5 magnification, for the external telescope for testing. If you do not have one, see the details in the next slide. And finally, educate your staff and obtain some implants. The following information can be sent to you upon request. 1. The OriLens Implantation Manual. 2. The OVT program. 3. An explanation and presentation of the OVT. 4. If you don't have an external telescope with 2.5 magnification, we can send you the details where you can purchase one. 5. Conversion tables between Snellen and ETDRS with different working distances. 6. Calculated post-op refraction table. Here is our contact information. Optolite is located in Herzliya, Israel. Our website is www.optolite.net. And you can contact either Dr. Lipschitz at lipschitz.netvision.net.il, or for commercial and sales, contact Yariv at optolite.net. Thank you so much.